So good morning, everyone. Thanks for attending the session entitled Tracking Trends Around the World. The first speaker would be Andrew Yuen from UCL School of Pharmacy, UK. The title is Gabapentinoid Consumption in 65 Countries and Regions from 2008 to 2018, a longitudinal study.
Good morning, everyone. Thank you for waking up so early this morning to attend this session. My name is Andrew Yuan. I'm a PhD student from the University College London School of Pharmacy. Today I'm going to present my study regarding the gabapentinoid consumption in 65 countries and regions from 2008 to 2018. And it's a longitudinal trend study. This paper has already been published in Nature Communication, and you can access this paper at this link here. So here are the disclosures, and we would like to thank IQVIA for sharing the database for us to conduct this study here. So let's talk a bit about gabapentinoids first. So gabapentinoids, they're originally developed for seizure or epilepsy. They work by inhibiting the alpha-2 delta subunits of the voltage-gated calcium channels, and hence reduce the release of neurotransmitters in our body, especially in our brain. Some of the licensed indications for around the world, including neuropathic pain, fibromyalgia, prospective neuralgia, restless leg syndrome, so on and so forth. However, pain and other off-label conditions are often accounting for the majority of their use, as indicated in previous studies. So why are we studying gabapentinoids here? Why is it so important? So we've seen an increasing trend of its overlapping use with opioids and benzodiazepines, not just in the UK or in some other countries as well. And we've also seen a potential of misuse of gabapentinoids, also indicated in previous studies, as they produce euphoric and relaxation effects. At the same time, the misuse and potential addiction can also lead to potential hospitalization or mortality, which can be critical to our public health system. And especially patients who have a history of substance abuse or any psychiatric comorbidities are especially prone to hospitalization or mortality of gabapentinoid abuse. So here are the objectives of this study here. So like I said, we're looking into the consumption trends of gabapentinoids in 65 countries across the world from 2008 to 2018. And the results will be stratified according to the country's income levels and the geographical locations. So the database that we've used here is the IQVIA Multinational Integrated Data Analysis System, also known as MIDAS. It's a database that captures the sales volume of pharmaceutical products from different distribution channels, including manufacturers, wholesalers, hospitals, and retail pharmacies. The database has been validated against external data sources in previous studies and also used as a proxy to evaluate multinational consumption of medications. And however, there's no patient-level data captured in this database, so we don't have any information on patient demographics here. So we've extracted the sales data from this database here between 2008 and 2018 for gabapentinoids. And in terms of gabapentinoids, we've included gabapentin, pregabalin, and gabapentin enacarbil, which is a prodrug of carbapenem. These drugs are identified by the WHO Anatomical Therapeutic Chemical Classification codes. It's noteworthy that mirogabalin is not included in this study because it was only licensed in 2019, which is out of the study period here. All countries or regions were developed based on the geographical regions according to the United Nations standard country or area codes for statistical use. The units that we used here is the defined daily dose, also known as DDD, per 10,000 inhabitants per day. So together we call that as the DDD per TID. So the national annual consumption rates were calculated with a 95% confidence interval estimated by the Poisson method. Multinational and regional annual consumption rates were also calculated by pooling the estimates from individual countries using a random effects model. Average annual percentage change in DDD per TID with 95% confidence interval was estimated using a linear regression model with log transformed consumption in DDD per TID as the dependent variable and year as the independent variable. Multinational and regional annual percentage changes were estimated using linear mixed models, controlling for within country correlations and according to the first order autocorrelation between years. The results were then stratified based on country income levels. In other words, lower middle income country levels, upper middle income country levels, and high income country level. So here are the results. So what we've seen here, we see a consistent increase of gabapentinoid consumption throughout the years. So in overall, for all multinational increase, for average annual percentage change was 17.2%. And as you can see here, the purple line here is representing the overall consumption of gabapentinoids, whereas the yellow line here is the consumption increase of pregabalin, the consumption rate of pregabalin, and the blue line here is the gabapentin, and the green line here is the gabapentin and ecarilbyl. So you can see that majority of consumption increase is accounted by the increase in pregabalin consumption here. And gabapentin consumption and gabapentin and ecarilbyl consumptions are pretty stable here, with a slight increase for gabapentin here. And here we can look at, we have all the consumption rates from all the included studies in the country, in the study here. So the blue bar here is representing the consumption rate of pregabalin throughout the years, so from 2008 till 2018. And the red bar here is showing the consumption rate of gabapentin, also from 2008 to 2018. As you can see here, like majority of the consumption increase, like I said, are accounted by the pregabalin consumption rate increase. However, there are some exceptions. As you can see, countries like Puerto Rico, United States, or New Zealand down here has a longer red bar here. And we'll explain the reason later on. But overall, we can see that there are three top countries with the highest consumption rates are United States, Puerto Rico, and United Kingdom. And here are the average annual percentage change of gabapentinoid consumption on all the study countries. So for all countries here, you can see there is an overall increase of gabapentinoid consumption, except for Venezuela. Venezuela is probably due to their economic downturn since 2010. So that's why it's an exceptional case here. But for the rest of the countries from around the world, we've seen a consistent increase of gabapentinoid consumption. And it's worth noting that some of the East Asian countries like China and Japan have shown a prominent growth in the 11 years. And here we try to visualize the change in consumptions of gabapentinoids, and we compare 2008 to 2018. So here we've colored all the study countries, and the lighter the color, the higher the consumption. So in 2008, we can see that countries like United States or Canada or countries in Europe, they've already shown a lighter color, and the same appears in 2018 as well, and the color only gets lighter. So in 2018, we see that the countries with the highest gabapentinoid consumption rates are countries in North America, Europe, and also in Oceania, as you can see here. So here we further stratify the results by their income levels. So we're showing the average annual percentage change at the top here. It shows that upper middle income level countries and also lower middle income countries are having a higher increase in annual percentage change of gabapentinoid consumption. However, in 2018, if you look at the absolute consumption rates, the high income countries still account for the majority of consumption and are showing a 6 times high consumption rates when compared to the upper middle and lower middle income countries. So what are the possible explanations for the trends here that we've seen? As we can see, as I mentioned at the very beginning, we've seen an increasing in prescribing habits for off-label and pain indications in the past, and this may account for the overall increase of gabapentinoid consumption in the previous 11 years, like from 2008 to 2018. And there are also potential concerns regarding the misuse and abuse of medications like opioids and benzodiazepines, and gabapentinoids are often perceived as a safer alternative when compared to these two counterparts here. And there are also less stringent regulatory requirements when it comes to prescription of gabapentinoids throughout that 11 period that we've studied. So for example, gabapentinoids, they are only prescription drugs in some of the countries that we've studied, whereas opioids and benzodiazepines are often classified as controlled drugs or dangerous drugs in some of the major countries here. And however, we've also seen like a high level of co-prescribing as indicated in previous studies with opioids and benzodiazepines. So we should not ignore the co-prescribing issues with these two medications as well. And there's also reports of rising cases of misuse of gabapentinoids in various countries. Like I mentioned, we've seen an interesting trend in some countries when it comes to the consumption of gabapentin and pregabalin. Although like most of the countries have high consumption rates of pregabalin, we've seen an exception in US, Puerto Rico, and New Zealand. In the US, we suspect that is probably due to the different regulation for pregabalin as compared to gabapentin, because in the US, throughout the study period, pregabalin was still classified as a federal Schedule V controlled substance there. And a similar situation happens in New Zealand, as pregabalin was not subsidized by the local pharmaceutical management agency, the Pharmac there. That's why there is a different treatment, like different preference for the local physicians in New Zealand as well. And we think there should be a further study to investigate the effects of further regulatory change, especially in the UK, because they recently changed the prescription status for gabapentinoids from a prescription drug to Schedule III controlled drugs in 2019, and that may have an effect towards the consumption of gabapentinoids down the years. So what are the implications then? We think that international and national regulatory bodies may have to consider reviewing the current guidelines towards the use of gabapentinoids. At the same time, we may have to monitor effects of the change of legal scheduling and also some labeling requirements that are being implemented in recent years, for example, in Canada, New Zealand, US, and UK. And we should also understand more about the exact cause behind such prominent increase, as this has not been seen in other medications. So overall, this is the first study to report the overall consumption of gabapentinoids in a global scale. And we have seen like a more than 4 times increase of gabapentinoids throughout the 11 years of study period. And there's an average increase of 17.2% per annum that we've seen. And we see that high-income country levels still remain to be the largest consumers of gabapentinoids. And upper middle income countries and lower middle income countries are catching up gradually. So I would like to thank my co-first author, Adrian, and also all the supervisors and co-authors for the support and supervision. Thank you.
We have a few minutes for questions. If anybody has any, go up to the microphone.
Hi, Leslie Wise, an independent consultant. Thank you. That was a very interesting presentation, telling quite a very clear story. I wondered if you had considered looking at standardizing for the age distribution within your countries, because these drugs can be used, as you know, for neuropathic pain, and we have aging populations in a number of the upper income countries. And I just wonder whether you might see slightly different results if you standardize for age distribution. The other comment I have is just a caution. Pain is not necessarily an off-label indication.
Pain other than neuropathic pain?
Well, yes, but in most prescribing electronic health records, doctors are notoriously lazy. They will not write neuropathic pain if they can just write pain. So I would just caution that you can't necessarily assume that all pain is off-label. It is difficult to classify.
Yeah.
But anyway, my main question was really around age, and also against changing trends in opioid use, whether there is an upward tick in gabapentinoids and a downward tick in the opioids which people were trying so hard to control.
Yeah.
That was all.
So first, yes, I absolutely agree that we should look into the results in different age groups. That would be really helpful for us to learn more about how severe this issues here is affecting different age groups. However, as I've mentioned at the very beginning of the study, the database here is only like a cells database.
Yes.
So it doesn't have any patient level data here. So if we need to look into like like the effects of the increase in different age groups, we may have to get access to local databases to have a further evaluation in that sense. So that would be great. Yeah, absolutely. In fact, that's what we've received from one of the comments from the reviewers when we try to publish this paper. But unfortunately, we haven't got that patient-level data here.
Let's pick that up afterwards. You and I could have a conversation.
Okay.
about that.
But yeah, for opioids, yeah, we have, there's another study utilizing the exact same database, which has also been published recently. They're looking into the opioid consumption. So from the same database, we can see there is like a decrease in opioid consumption in certain countries, not
Yeah.
every, like for example, like middle-income countries, they have an increasing trend of opioid consumption, whereas like high-income countries, you can see like a gradual decrease of opioid consumption. So we can see like there is a gradual substitution from opioids to gabapentinoids, but yeah, it's not like so we need to still look into the exact reason behind, like whether it's actually due to the decrease in opioids or whether there are any other possible effects affecting the increase, affecting consumption of gabapentinoids here. So, but yeah, further studies would be required, but we can see that like sort of crossover that you've mentioned
Yeah.
in previous studies.
Thank you.
So the next presenter is Jenna Wong from Harvard Medical School and Harvard Pilgrim Healthcare Institute, Boston, US. She will be presenting, is tolpidem still the top medication used for insomnia? Trends in dispensing of tolpidem and low-dose trazodone for new and continued use among commercially insured US adults, 2011-2021.
Okay, great. Good morning, everyone. Thank you for coming. And so I'm Jenna Wong. I'm from the Department of Population Medicine at Harvard Medical School and Harvard Pilgrim Healthcare. So in this talk today, I'm going to be presenting about the latest trends in the dispensing of the two medications most commonly used for insomnia. And before I begin, I wanted to acknowledge my co-authors, Susie Burdish and Darren Toe. And I have no conflicts of interest to disclose. So insomnia is the most common sleeping disorder in adults, and 1 in 3 adults experience insomnia symptoms of troubles falling asleep at night or staying asleep at night, waking up too early in the morning, or getting good quality restorative sleep. And 1 in 10 adults meet the clinical criteria for insomnia disorder. Age and sex are the most clearly defined demographic risk factors for insomnia, with increased risks in women and older adults. And in addition to being a very common medical disorder, insomnia also has a host of negative consequences on the quality of life and health of individuals, as well as society, including decreased workplace productivity and increased healthcare costs. So there's 2 main types of treatments for insomnia. The recommended first-line treatment is actually cognitive behavioral therapy, which has traditionally required access to a trained provider. But even despite efforts to try and make this form of treatment more accessible to patients through the internet and digital apps, its uptake in practice is still far below that of pharmacotherapy, which is more often used as first-line treatment in practice. And the 2 main medications that are used for insomnia are zolpidem, which is from the class of Z drugs approved for insomnia, and trazodone, which is a sedating antidepressant that is not approved for insomnia, but it's commonly used off-label for this indication at dosages that are lower than the therapeutic dosages indicated for depression. And if we look at what the clinical guidelines say about the use of these medications for insomnia, The most recent U.S. clinical guideline in 2017 reviewed the available efficacy and safety data on these two medications from published RCTs, and they concluded that for zolpidem, the benefits outweighed the harms, although marginally. So they recommended zolpidem, whereas for trazodone, they did not recommend its use because the harms potentially outweighed the benefits. And notably, the conclusion for trazodone was because when they went to go evaluate the benefits, there was almost no RCT data to look at the benefits of trazodone for insomnia. So if we contrast these guidelines with real-world practice, we showed in a previous analysis that in the US, from 2011 to 2018, the dispensing of zolpidem was steadily declining, whereas the dispensing of low-dose trazodone was steadily increasing. But by 2018, the levels were still below those of zolpidem in the US. And the likely reasons for these opposing trends are that physicians are becoming increasingly uncomfortable prescribing zolpidem because of increasing safety concerns, given that zolpidem has had 2 FDA warnings in the last decade. It's a Schedule IV drug, and it's on the Beers criteria list, unlike trazodone. So in this study, we wanted to update and extend our previous analysis, and we wanted to more clearly elucidate what is the current state of dispensing of both of these drugs. So we addressed 3 questions. The first is, by 2021, is zolpidem still being the top drug dispensed for insomnia? And so this is 2 years after the onset of the pandemic and more than 4 years after the publication of the recent US guideline. Second, what proportion of all dispensing that we see for these drugs is for new use? And then third, do these dispensing trends differ by age or sex? So our data source, we use the Merative MarketScan research database, which is a large commercial claims database capturing individuals in the US with employer-sponsored insurance or Medicare supplemental or Medicare Advantage plans. And we created 11 annual cohorts, 1 for each calendar year in our study period, and each cohort contained adults that contacted the healthcare system in the year and had at least 12 months of prior medical and drug insurance. And then we measured our study variables separately for each annual cohort. We defined adults as having been dispensed zolpidem if they had at least 1 dispensing in the year, which could be for any daily dosage. For low-dose trazodone, we required at least 1 dispensing that had to be at or below 100 milligrams per day, which is a conservative low threshold that's indicated for insomnia. And we also required that all of their dispensings for trazodone during the year be within this low-dose threshold. And then we classified these individuals as new users if they did not have dispensing of either drug in the last 12 months before their first dispensing of the drug in the year. Then for each drug, we calculated the annual proportion of adults that had at least 1 dispensing. And then among those adults that had a dispensing, we calculated the annual proportion of those individuals that were classified as new users. Then we measured trends over time. So we estimated the mean annual % change over the study period, which we estimated using binomial regression adjusted for age and sex. And we conducted this analysis overall, and we also stratified by sex or age group. So across our study period, the annual cohorts contained an average of 15.3 million adults. And as you can see, the size decreased over the study period, which is a finding that has been reported by others using the MarketScan data over time. The average median age was 47 years, and there were slightly higher proportions of females than males in that cohorts. So this graph shows the overall prevalence of dispensing of zolpidem in the blue and low-dose trazodone in the orange over the study period, updated to 2021 now. So you can see that there has been no change in the direction of the contemporary trends that we had been observing, and there really has been no impact of the US guideline or the COVID pandemic in changing what we had been seeing prior to or up to the end of 2018. And also we can see that starting in 2020 that the levels of trazodone dispensing began to surpass those of zolpidem and have continued. Then when we stratify the analysis by sex, we can see that the trends are similar in males and females, with the trends just being more pronounced in females because they had higher levels of dispensing of both drugs. When we stratified by age, we found that in older adults, there was a very brief decline in the proportion of adults being dispensed trazodone just for 2018 and 2019, but resumed increase in 2020. And beyond those 2 years, overall, the trends are very similar by age, with older adults having more pronounced trends because they had higher levels of dispensing of both drugs. And then now if we look at the proportion of dispensing to new users, we found that for zolpidem, over time, the proportion of new users was decreasing. So it decreased from 41% to 27% over the study period. And for trazodone, it increased slightly from 43% to 47% over the study period. Stratified by sex, you can see that the overall trends were very similar in males and females, the only difference being the magnitude of the trend. So males that are shown along the top, the decrease in the proportion of new users was more pronounced in males than females, whereas for trazodone, the proportion increase in new users was less pronounced in males than females. And when stratified by age, we found that among older adults only, in 2020, there was a spike in the proportion of new users. So this was for both drugs. We can likely attribute this to the COVID pandemic. And also among older adults for trazodone, the proportion of new users has stayed relatively stable over time. So in summary, we found that by 2021, the dispensing of low-dose trazodone has surpassed zolpidem in all age and sex groups. We also found that for zolpidem, the proportion of dispensing to new users has decreased over time and accounts for about 1 in 4 users dispense zolpidem by 2021. For low-dose trazodone, there's been a slight increase in the proportion of new users, accounting for 1 in 2 adults dispense this drug in 2021. And overall, the levels of dispensing of both drugs were highest in females and older adults who we know are at higher risk for insomnia. And so I just wanted to close with 2 key takeaways from this study. So first, it's clear that there is a persisting propensity among clinicians to prescribe low-dose trazodone for insomnia, even though there is very little evidence to show that it is effective for this indication, and also it's not currently guideline recommended. And so because of that, there's a timely need to better understand what are the comparative benefits and harms of using trazodone for insomnia, and this will help inform the current clinical practice trends that we're seeing in the US. So with that, I wanted to thank you for listening, and I'd be happy to take any questions or comments.
Thank you for the presentation. The trazodone you use, is it an extended release formulation or rapid release formulation?
Both of them. I used all of the DINs for trazodone, so I think that would have included both.
But do you have actually a rapid release? Because for depression, it's usually the extended release, a retard formulation. In Europe, we have rapid release as a liquid or as tablets, which are rapid releasing, but it's unusual.
Okay, so sorry, that's for trazodone in the.
For trazodone,
Oh,
yeah,
okay.
I spoke about trazodone.
I think I would have to go back and look at the DINs, and then if I can go look at the manufacturer, the
Yeah,
name of
yeah.
the exact.
It's important because for off-label use, we usually use the rapid release formulation, which we also don't have it, but we import it from Germany. And they have a rapid release tablet, and Italy has a liquid formulation because you avoid the hangover and the adverse effects of trazodone.
Okay.
Because if you have the extended release, which is licensed for depression, you have the problem, you have a hangover the
Right.
next day. And
Right.
that's-
I see.
That's one thing. The other thing is that the trazodone has the advantage that it's anxiolytic, and you don't get, and it doesn't suppress REM sleep. Well, the Z substance, I'm not sure, zolpidem, zopiclone, they somehow influence the REM sleep, and I think that's the reason why it's increasing in trend. You don't get dependent on that.
Right. Yeah. And so I agree. I think there are a lot of reasons why physicians are doing it, and it's clear, like, the physicians are saying there's something about it that we would like,
Yeah.
and the evidence isn't
Yeah.
there. So it's helpful to hear perspectives about like why it could be. And I think, like, me as a researcher interested in these drugs and studying them further, like, to hear what it is that you're finding, and so that we can study that and produce the evidence that is needed to better bridge the gap right now between the guidelines, which they're sort of put in a box because they have to follow what it is like an evidence-based rubric, but they don't have the evidence for that. So
A study should be done. I think that if you have a rapid release formulation, you can even increase the dose 150 milligram, but only give it evening before sleep, because then in the morning there is no
Right.
adverse effect anymore.
okay,
Or
that's
shouldn't.
interesting.
Yeah.
I will. I'll keep that in mind, and I'll look at that. Thanks.
Just briefly, because we're at time for the next speaker.
Sorry, okay. Heather Neville, I'm from Halifax,
Hi.
Nova Scotia Health. So we're seeing a similar trend with trazodone being used in hospitals as well.
Okay. Yeah.
I was just curious, ZAD drugs are variously approved, different ones are approved in different countries, so I wondered if there were any other ZAD drugs available in the States other than zolpidem.
I think they're all three available. So zopiclone, azopiclone, and zolpidem, but they're like not used nearly as much as zolpidem. So you wouldn't see like any bump in the results if you were to add them all together. Okay. Yeah.
Thank you.
So next speaker is Georgina Hughes from the University of South Carolina. She will be presenting national trends in antidepressant utilization within Australian residential aged care facilities.
Cool. Good morning, everyone, and thanks very much for being here this morning. I'm Georgina. I'm a pharmacist and a PhD student at the University of South Australia. Today I'm presenting some of the work from the first study of my PhD, which is looking at the national trends in antidepressant use in aged care facilities. Briefly, we have some disclosures, but no conflicts of interest. This is just some funding that supports the people on my study and my PhD. So by way of background, residential aged care facilities in Australia work very similarly to nursing homes or long-term care and care homes in other countries. We're often providing care for older people who can no longer live independently at home. And we know that depression is particularly common among older people who are living in nursing homes. For example, in 2019, the World Health Organization estimated that 1 in 20 older people who are aged 70 years or older lived with a depressive disorder. However, we can compare this to other information in the literature which suggests that this can be as high as 1 in 2 individuals who are living in aged care facilities. We know that antidepressant medicines are recommended for the moderate to severe major depression in conjunction with the use of non-pharmacological interventions such as psychological therapies. However, recently in Australia we did a nationwide study which estimated that as little as 3% of residents of aged care facilities are living with mental health conditions or actually accessing government subsidised mental health services. The graph on the left here is some data from another study that was done by other members of our team at Rosa, and it looks at the proportion of individuals who are using different types of psychotropic medicines in the lead up to and following entry to aged care facilities. And what we can see here from the blue line on the top is that antidepressants are clearly the most frequently used psychotropic in aged care facilities, and that the use of these medicines increases both in the lead up to and following aged care facility entry. We're particularly concerned about the use of antidepressant medicines because we know that they can contribute to medicines-related harms, whether that be the day-to-day side effects such as urinary incontinence or dry mouth, or more longer-term outcomes such as falls and fractures or cardiovascular events. Briefly, this is a bit of a refresher on the different classes of antidepressant medicines. And over the last 20 to 30 years, we've seen the introduction of newer antidepressant medicines such as SSRIs and SNRIs, and a reduction in the use of older antidepressant medicines such as our tricyclic antidepressants. In the literature at the moment, there's a recent systematic review and meta-analysis that estimated that around 38% of residents of aged care facilities are using an antidepressant globally. However, when we look at the literature more closely around studies that are looking at the changes in the use of these medicines over time, most studies are small point prevalence analyses. And so we proposed this study which aimed to examine the trends of antidepressant use in aged care facilities on a national scale over a 14-year study period in Australia. To do this, we undertook a repeated cross-sectional study which included all long-term permanent residents of aged care facilities who were aged 65 to 105 years on entry between 2006 and 2019. To do this study, we used information from the National Historic Cohort of the Registry of Senior Australians. And this registry includes linked health and aged care information for all older people who've accessed government subsidised aged care services from 2002 onwards. In particular, to ascertain our antidepressant use, we used our data set, the Australian Pharmaceutical Benefits Scheme. And this is a pharmaceutical claims database which includes all medicines that are dispensed to individuals in Australia under this scheme. And it maps item codes to our World Health Organisation ATC codes. Broadly, in our study, we had two main outcomes of interest. We were interested in the annual prevalence of antidepressant use, as well as the annual number of defined daily doses that were dispensed per 1,000 resident days. We analysed our trends using Poisson regression models which adjusted our rates for age and sex and also accounted for autocorrelation over our study period. So this gave us our adjusted rate ratios and confidence intervals, and we used negative binomial regression models where there was overdispersion. And in this study, that was the case for our defined daily doses. We also stratified our crude prevalence rates by sex, dementia, and depression diagnosis. So these are some of the characteristics of our overall cohort, which included 779,659 residents from over 3,000 aged care facilities over the study period. We had about 2/3 of residents who were females and a median age at aged care facility entry of 85 years, which is consistent with what we would expect from other studies in this cohort. We also estimated our comorbidity score at aged care facility entry using a validated tool that analyses pharmaceutical claims data for the 6 months prior to entry, and this estimated about 5 comorbidities per resident. We also looked at the dementia and depression diagnoses across the study period, and for this we used information that was ascertained from aged care assessment information. We had complete data capture of this information from 2009 onwards, and this estimated that dementia decreased from about 55% in 2019 to just under 50% in 2009 to just under 50% in 2019. However, our depression diagnoses increased from about 1/3 of individuals up to over 40% over the study period. These are some of our results from the adjusted rates of prevalence, and we can see here that overall antidepressant use increased by about 2% on average each year. And that increased from 46.1% at the start of the study period to almost 60% or 58.5% in 2019. And we can see in the plot below here that it's very evident that mirtazapine is really driving the increased utilisation of the antidepressant use. It more than doubled over the study period, and our risk ratio here indicates that it was on average an increase by about 7% each year. We're particularly concerned about the increased use of mirtazapine medicines because it's a tetracyclic antidepressant that has sedative properties, and it's also got weight gain properties as well. And so when we think about our population of people who are living in aged care facilities, we know that there is evidence for chemical restrictive practice, and we also know they're often underweight and frail. And so it's highlighting here that potentially they might be being used inappropriately. When we look at our other classes of medicines, we can see a small reduction in the tricyclic antidepressants, which we would expect, and also an increase in the use of SNRIs. However, this was largely driven by the introduction of duloxetine and desvenlafaxine to our Australian market, which was during our study period. When we stratified our crude rates by dementia, we found that residents living with dementia, which is the bottom line here, the solid line, had a greater increase in the prevalence compared to those living without dementia. But by the end of our study period, it was roughly similar. What's particularly interesting about this is that we found that that increase was particularly so from 2016 onwards, which in Australia represented a time where we released some of our first clinical practice guidelines around the use of psychotropic medicines for the management of change behaviours in dementia. Oh, sorry. Sorry. And what we found was that the SSRIs particularly drove this increase, and it was consistent with the types of antidepressants that were recommended in these guidelines. When we looked at the prevalence of depression stratified, we saw that at the end of our study period, only 2/3 of residents with depression recorded were dispensed antidepressants. However, on the other hand, 1/3 of residents who were using antidepressants did not have a depression diagnosis recorded. So this information indicates to us that potentially there might be some under and over treatment coexisting in our cohort. Perhaps our data study isn't completely ascertaining all of our depression cases, or perhaps medicines, some of the antidepressant medicines might be being used off-label. When we looked at our volume of antidepressant use and our defined daily doses, we found that our rates were really similar to our prevalence rates. In 2019, there was enough antidepressants supplied to treat 50.6% of our population across Australia in aged care facilities with an antidepressant at a standard dose on every day of the year. And our annual average increase was 3%. So this study was the first of its kind to examine antidepressant use among all Australian aged care facilities. We measured trends using two approaches, both the prevalence and the defined daily doses. We had a high capture of antidepressant use in this population and hence nationally representative findings. However, importantly, we were unable to assess the direct indication and appropriateness or inappropriateness of antidepressant use in this group. And we weren't able to assess switching between different antidepressants either. In summary, we found that nearly 3 in every 5 residents of aged care facilities were dispensed an antidepressant in 2019. This is a very high prevalence rate, and we know that it increased considerably across our study period. And we'd like to emphasise that this increase in antidepressant use was largely driven by the increased utilisation of mirtazapine, which was about 7% on average each year. And so we're particularly concerned that this might be being used potentially inappropriately and subsequently putting our residents at risk of harm. So there's a real pressing need to look more closely at antidepressant use in this cohort, particularly mirtazapine, and really prioritise the safe and appropriate use of antidepressants on a clinical level going forward. So just like to finish by thanking all of the people that support my PhD. Thanks.
Does anyone have any questions for Georgina?
Thank you for your presentation. Only one comment about the first commenter, the first slide, because I remember the SNRI also used for the some kind of the neuropathic pain a lot. Not still. I mean, this kind is still proven in some guidelines. So yeah, just remember, because the same comment as the first presenter. I mean, the aging is always on the way, right? So neuropathic pain is probably some kind of the disease underestimated.
Yeah, absolutely, I agree. And the data set that we use to look at antidepressant use doesn't have any information, unfortunately, around direct indication, which is why we couldn't really directly assess it. And we tried to stratify by depression and dementia as much as we could, but yeah, the use of these medicines in pain and also our tricyclic antidepressants, which are approved in neuropathic pain as well. Yeah.
It's a very interesting find that the increased trends of mirtazapine. Have you thought that probably because the sedative effect as opposed to SSRIs and the increase in appetite, maybe those increasing trends?
Yeah, potentially. I mean, without, like I said, without being able to directly measure it in our data set, anecdotally, that's what we're thinking that it might be being used for. We know in Australia at the moment there's been a lot of aged care reforms from about sort of 2018, 2019 onwards. There's been increased monitoring of antipsychotics, and a lot of information around the safe use of antipsychotics and benzodiazepines. So we haven't been able to do the study with the data yet around looking at the changes in the other use of psychotropic medicines, like we talked about with the trazodone and the zolpidem and things like that as well. But I think that's a really important research question to see if potentially there's some substitution from other psychotropics.
Thank you.
Thanks.
Thank you.
So our next presenter is Andrew Weisse from Vanderbilt University Medical Center, Nashville, Tennessee. He will be presenting risk of serious opioid-related harms associated with discharge opioid and non-opioid analgesic regimes among patients hospitalized with long bone fracture.
Great. So thank you for the opportunity to present some work that was led by Kyle Hart that I'll be presenting on his behalf. So this is a little bit of a different presentation from some of the prevalent trend studies that we've been looking at, but we'll go ahead and dive in. So here are my our group's disclosures. So as background, the prescribing of opioids after surgical procedures and traumatic injuries, especially at high doses, has been clearly associated with an increased risk of serious opioid-related events like developing persistent opioid use, developing opioid use disorders, and opioid-related overdoses. Specifically in the sort of trauma surgery world, multimodal analgesia has been one suggested strategy to help reduce post-discharge opioid requirements and potentially lower perceived pain to protect against opioid-related harms in a population in which opioids are warranted to treat pain. However, whether the use of prescribed non-opioid analgesics protects against opioid-related events after hospitalization for a traumatic injury like a long bone fracture remains unclear. And so we sought to compare the risk of serious opioid-related events among previously opioid-naive patients hospitalized for long bone fracture that filled opioids alone or in combination with at least one non-opioid analgesic. So for this study, we did use the Merative MarketScan commercial database. And to orient you to our study population and our study design, we can sort of walk through this figure. So every patient in our cohort entered the cohort on day 42 after discharge for their long bone fracture hospitalization. What that allowed us to do is to have an exposure interval from the day before discharge through day 41 after discharge to measure their analgesic use sort of in the standard post-surgical follow-up period. And so in that window, we assessed whether they used the types of analgesics they used across 4 different groups. So whether they did not fill any analgesic, whether they filled a non-opioid only, whether they filled an opioid only, or whether they filled both an opioid and a non-opioid. It's important in this context to consider that, or to keep in mind that we defined opioid combination drugs like hydrocodone, acetaminophen as an opioid only, whereas the non-opioids we are interested in were muscle relaxants, gabapentinoids, and NSAIDs. Finally, as it relates to the exposure, we also assessed the total opioid dose that they filled in that exposure window using morphine milligram equivalents and adjusted for that in all of our analyses using restricted cubic splines. Now for the outcome, it's first important to note that we started follow-up for patients at TNOT and followed them through the earliest of the occurrence of an outcome, enrollment loss, or day 365 after discharge. Our outcome of interest was a composite outcome that included developing persistent opioid use, developing evidence of an opioid use disorder, or experiencing an opioid-related overdose. Our persistent use definition was having a greater than 90-day supply in a 180-day period. And then for our covariates, first I want to introduce what our baseline period was. So the baseline period for everyone in our cohort was day 180 before admission for their long bone fracture hospitalization through day 41 post-discharge. In the pre-discharge portion of the baseline period, we did require everyone to be opioid naive, but we also required that they be continuously enrolled through that entire baseline period, so both the pre-discharge and 41-day post-discharge period. We assessed covariates during that entire baseline period, so that included a long list of patient demographics, factors associated with the long bone fracture hospitalization itself, like length of stay, whether there was any evidence of surgery, the type of fracture, for example. And then we also adjusted for pre-existing comorbidities like mental health conditions and certain types of pain indications. So for our primary analysis, we used Cox proportional hazards model with robust standard errors to calculate predicted adjusted hazard ratios at each observed value of total opioid dose within each of our drug regimens. So the opioid only, there was no dose in the non-opioid only, but we made that comparison, as well as the opioid and non-opioid, compared to the no analgesic prescription group as reference, accounting for all relevant covariates. And so we did that in the primary analysis so that we would be able to model the sort of dose response curve across dose in each of those categories. But we also wanted to make a more direct comparison of individuals who filled opioids who also filled non-opioids. And so we did conduct a secondary analysis in which we directly compared the risk of these serious opioid-related events in the opioid and non-opioid group compared directly to the opioid-only group, accounting for all covariates and opioid dose using trimmed inverse probability of treatment weights. So for our results, we identified over 35,000 patients with evidence of a long bone fracture. Most of these patients did fill at least one post-discharge opioid, so 80%. 24%, around 24% did fill an opioid and at least one non-opioid. A very small percent filled a non-opioid only. And then we did have 18% that did not fill any analgesic. Now, this was not the primary purpose of the study, but everyone else is presenting prevalence of drugs, so I wanted to try to squeeze this in for what we see in our particular cohort. So this is the prevalence of prescribing in our very small cohort of individuals with long bone fracture post-hospitalization. So you can see opioid prescribing is fairly stable. There was a small decrease in 2018 and 2019, whereas we see sort of minor increases over time for the other non-opioid analgesics like NSAIDs, gabapentinoids, and muscle relaxants. But on to the primary analysis. So to orient you to this figure, what we're demonstrating here are adjusted predicted hazard ratios at each observed value of opioid dose in our study population in each of our 3 drug regimens compared to the no analgesic group as reference. So it's important to note first that non-opioid analgesic group, obviously they didn't get any opioids, so there's no sort of variance across the dose distribution. I've just included that point estimate for reference. Whereas the green line represents the adjusted hazard ratios for the opioid and non-opioid group, and the blue line represents the point estimates for the opioid-only group. And so if we look at this dose distribution curve, if we were to zoom in at an MME of less than 300, we would actually see that the predicted adjusted hazard ratios in both of those groups is actually significantly less than 1, which would demonstrate at those doses in both groups there's actually a lower hazard for these serious opioid-related events compared to those who got no analgesic. However, as expected, as the dose increased in both groups, we see the hazard ratios increase fairly sharply so that they are significantly above 1, up to about 4,000 MME, and then we see that it levels off at a very high adjusted hazard ratio. So this gives us an idea of what the dose distribution looks like in those 2 groups. It also gives us our sort of first introduction to this possibility that there's a higher risk of these events in the individuals who get both opioids and non-opioids, although there's no direct comparison in this particular figure. And so that's where our secondary analysis came in, where we did make that direct comparison. And so when we compared the hazard in individuals who got both a non-opioid and an opioid, the adjusted hazard ratio was statistically significantly elevated at 1.90 compared to those who got an opioid only. So before we put these results in context, I want to highlight some strengths and limitations from the study. So we did rely on filled pharmacy data to characterize analgesic use. That obviously means that it doesn't represent actual use. It also means we're not capturing out-of-pocket prescriptions and over-the-counter analgesics. So particularly in the US, that means we could be missing some over-the-counter NSAIDs, for example. Additionally, we did identify and account for an extensive list of potential confounders. However, we recognize we can't rule out potential residual confounding. I'll also say it's likely that we're not completely able to control for confounding by injury severity or severity of pain after their fracture hospitalization and in all of our comparisons. And then finally, we chose to purposely focus on long bone fracture as one type of traumatic injury to try to limit confounding due to different pain management guidelines and underlying risks for different injury types. But we also recognize that likely limits the generalizability of these findings outside of individuals with long bone fractures. But in summary, in relation to this hypothesis that prescribing non-opioids might protect from these serious opioid-related events, we did not find any evidence that the combined prescribing of non-opioids with opioids after discharge lowered the risk of serious opioid-related events at any observed doses. That has important implications because these other non-opioids have their own safety concerns, right? We know with muscle relaxants, there are concerns around tolerability and dependency. And we also know that there's growing evidence that the combined use of opioids and gabapentinoids has been associated with an increased risk in opioid-related death. And so our findings actually seem to contribute to that growing body of literature raising concerns about the combined use of opioids and gabapentinoids. I'll note, we did also see that patients filling opioids at low doses, less than 300 total MME, in the post-discharge period had a significantly lower risk of developing these serious opioid-related events compared to those that did not fill an analgesic. So again, that highlights that in this population in which these patients have experienced a fracture, they need to have their pain managed, there's evidence that there are safe doses that can be prescribed that do not put these patients at an increased risk. And so ultimately, we'd like current guidelines around prescribing after long bone fracture hospitalization to consider the risk of serious opioid-related events imparted by these various pharmacologic drug regimens after long bone fracture hospitalization. Thank you.
Hey, Andrew, thank you. I think you touched on this in the limitations, but I understand that all patients had long bone fractures. Did you identify if there were any other comorbid injuries, like spinal injuries or others?
Yeah, so those would be captured in sort of in the pain indications. So pain injuries, pain indications and prior injuries, yeah. Okay. We'd be picking that up.
Did you exclude patients with prior outcomes?
Yes, yeah. So, yeah, sorry, I didn't mention that. So, yeah, they were opioid naive, and this was their first long bone fracture, and we specifically excluded individuals with prior opioid use or with opioid use disorder or with opioid-related overdoses. Yeah.
Okay, thank you.
Thanks very much for the presentation. It's an interesting topic. I was wondering about the baseline period going kind of after the discharge or into the discharge almost period. Could you just run by the follow-up and baseline covariate assessment periods,
Sure,
exposure
yeah.
window? Yeah, thanks. So, did you see any? So was there any? There was no overlap between the exposure assessment and the outcome.
Right, no,
Okay,
and that's
yeah,
an
okay.
important point. So the no prescriptions filled in that baseline period could contribute to the persistent opioid use outcome.
Okay,
Yeah, so
yeah.
those days supply wouldn't extend into the follow-up period. They would have to fill new prescriptions for 90 days.
Yeah, and you didn't see any potential for like intermediate variables in that time to be adjusted for, I don't suppose.
We did, but so they get adjusted for as a part of the other covariates. For example, if they were readmitted in that window of time, we would control for whether or not they had been readmitted or experienced other sorts of pain indications that might have happened, yeah. So
Okay.
it's looking at both the pre and post-discharge period.
Great. Thanks very much.
Yeah.
Thank you. Next presenter is Oliver Scholle from Leibniz Institute for Prevention Research and Epidemiology, Germany.
Yes.
He will be presenting prescribing of opioid analgesics in Germany, opposite trends when different quantification measures are used.
It's a long word of an institute. Yeah, I'm happy to present our results here on trends of prescribing opioids in Germany. These are my disclosures, and this project was funded by the German Federal Institute for Drugs and Medical Devices. So first, a few words about the relevance in prior research. As you all will know, trend studies on drug utilization may inform regulatory medicines agencies, public health agencies, or federal ministries to support their decision-making. And regarding opioids, there's a lack of data on recent trends in Germany based on individual level data. So there are quite new, when a new calendar year is coming, there is data on prescribing, but only in total based on the DDDs and not on individual data. And most studies in this field focus on prescription prevalence, while only few studies use quantification measures that consider the amount and potency of opioids, such as the morphine equivalency. So the objective of our study was to assess trends in prescribing opioid analgesics in Germany using different quantification measures. We used the German Pharmacoepidemiological Research Database, in short JEPARD, which is a health claims database covering about 20% of the German population. We conducted annual cross-sectional studies for the years 2004 to 2020. And we included persons with continuous insurance in each calendar year, or those who were born or died in the respective year. JEPARD contains outpatient drug dispensations, and we included all prescriptions of opioid analgesics in this study. As quantification measures, we first calculated the prescription prevalence, defined as the number of persons with at least one prescription per 100 persons, and also the sum of prescribed oral morphine equivalents in milligram per 1,000 person years. And as it is important for this study, and it has been mentioned before, but maybe just briefly on the oral morphine equivalents, it's the amount of equianalgesic oral morphine, and we calculated them for each package, for each dispensed package, based on the ATC code and also the route of application, and then multiplied the amount of the active ingredient in each package with a factor. And for example, here for buprenorphine, there are two different routes of application, so sublingual, transdermal, and parenteral. And unfortunately, there's not one database covering all factors, so we tried to, took into consideration a couple of references and decided then for the most commonly mentioned factor. We calculated both measures overall and stratified by age group and sex. And we also directly standardized them according to age and sex to the German population. So coming to the results, these are the prescription numbers on the prescription prevalence per 100 persons. And the sample size here ranged from more than 11 million in 2004 to 17 million people eligible for the study, so the denominator. And as you can see here, the standardized prescription prevalence steadily decreased from 2004 to 2016 by about 18%, and it further decreased thereafter. However, when we looked at the oral morphine equivalents, we saw a very different picture, at least until 2016, where there was an overall increase by about 55% and a slight decrease thereafter, so the same as with the prevalence. Stratified by sex and age group, we see here on the upper left that there was a decrease in the prescription prevalence in almost all age groups in females. However, in those females aged 80 years and older, there was an increase, and also in males, it was just at the beginning of the study period and then remained stable. For the oral morphine equivalents, it was also interesting that it was driven, like the trend, from females aged 80 years and older, where there was a relative increase of about 90% from 2004 to 2016. Yeah, that's the whole picture again. So when we draw three main conclusions out of our results. So first, we've seen that considering oral morphine equivalents, the overall prescribing of opioid analgesics slightly decreased between 2004 and 2016, and it's also increased, I said, yeah, and it decreased thereafter. And the strikingly sharp increases we've seen in the elderly women aged 80 years and older obviously had declined thereafter. So that suggests no alarming trend in opioid prescribing in recent years in Germany. And because the literature before we conducted this study was based actually on data until 2016, and the conclusions were that there's no opioid crisis in Germany. Of course, also many other outcomes are belonging to or are needed to conclude on whether there's a crisis or not, but at least regarding opioid prescriptions, that was the conclusion. But there are also open questions for further research, and we are just at the beginning of the analysis in this project. So maybe the most important would be also from the regulatory perspective, what were the drivers for the increase from 2004 and to 2016? And there are different possibilities we will look at. So whether doses higher of the same opioid, or did the duration increase? So we will also look at long-term use of opioids in the future. There could also have been switches to opioids with a higher potency, which could explain this increase. And it might also be possible that additional opioids may have been prescribed, such as transmucosal fentanyl in addition to fentanyl patches. And also, of course, the population could have changed. So maybe there were more cancer patients in this time where the increases took place. And the third and last conclusion is on methodological lessons. We learned, so we've seen that overall trends can be driven by specific age and sex strata. So it is important to stratify by age and sex, and this may seem self-evident for pharmacoepidemiologists, and other presentations also did this. But as I said, at least in Germany, the most recent prescription data published in each new calendar year are not available by age and sex. So, but nevertheless, these results are often or receive high attention in the media, which could also lead to unjustified fears being raised. And actually, based on the DDD, so what is published in each new calendar year, there was a steady increase also since 2016, and so we kind of showed that it's not that alarming as it might be. And we've also seen that there are opposite trends for the prescription prevalence as compared to oral morphine equivalents. So interpreting trends could strongly depend on the quantification measure being considered, and also might lead to different regulatory decisions. So our appeal is that researchers should consider also to assess different quantification measures in drug utilization trend studies. And actually, when we applied for the grant proposal, we only included prescription prevalence, and then as we knew we couldn't going to conferences the last year, we asked whether we could use the money to also look at another quantification measure. And this is how this all came up, and we were quite surprised about the results. So to end, I would like to thank the statutory health insurances providers for providing data for the study, and also the whole study team, of course, and thank you for listening.
Hello, Ursula Kirchmeier from Rome, Italy. Thank you for this very interesting presentation. Just two questions. First, are you aware of clinical guidelines, for example, for chronic pain management in the years when you saw an increase? Because I know that in some countries there was more attention in the recent 10 or 15 years on this topic, and I think older women are typically suffering from chronic pain of the bones or others, so it might not only be about cancer. And then my other question is, do you have the chance also to look at new users on the incidence of uptake, if there are more people newly using the opioids?
Thank you for the question. For the first question, yes, it's, there was I think the new guideline with the highest evidence grade on long-term use in non-cancer pain was published in 2017. So maybe that's also the reason that it then flattened, like the oromorphine equivalent, especially in older women, because they were discouraging using opioids, long-term use for non-cancer indications. And yeah, the second one, yes, we will also look at, but we will, of course, yeah, then conduct a study in new users and also look at this. So we will also calculate the incidence rates later in the project. Yeah.
I have a question also concerning the use of the opioids. Is methadone included, and polymethadone, levomethadone, which is usually not pain indication but indication for substitution? And can you actually differentiate between pain, any kind of pain, and substitution of addicts, also especially morphine? Because at least in Austria we could not, if you have a prescription of Mundidol, which is a morphine, a retard formulation, we cannot distinguish whether it is prescribed for pain or for substitution.
Mm-hmm. We are in a lucky situation at our institute to have a pharmaceutical reference database, and they're doing a lot of effort also to make a database out of all drugs that were available in Germany, and with it's kind of a German modification of the ATC code based on the WHO ATC codes, and this is a little bit more detailed. For example, also homeopathic are included because they are quite common in Germany. But yeah, in the ITC code we are using is dividing into pain, whether the main indication of the package or of the drug is pain or opioid substitution. It is. So we can differentiate and check between this. And from my experience, because I also worked in pharmacies, they also very rarely prescribe morphine like this, but it's more like polamidone, and also like made in this bottle. I don't know the word in English now, but the bottle where they should drink it, you know, with sugar, so that you couldn't inject it. Yeah, so we can differentiate between them.
But do you see increase, for example, in the substitution one? Is the
it's not included here because we only use the analgesic codes.
Okay, you used
but in the project we looked at this. The numbers were very low, at least for the prevalence, but we've seen for the prescription rate, because oromorphine equivalents could not be calculated for every substitution drugs. We also seen some increases in the prescription rate, at least. But in Germany, it's quite restricted also. Like when they are in a program, they're only allowed to get, if at all, one for 1 week, and then they should come back to the physician. So it's and maybe that's also that was also concluded that these restrictions and strict prescribing guidelines are the reason that Germany is, although for example, the consumption of high opioids is even higher as in the US, but maybe it's because of the prescription guidelines.
Okay, thank you.
Did you have the opportunity to look at, to explain the trends, the increasing trends in IME, if higher potency opioids were being used at the end of the period, or maybe higher doses?
Yeah, that's what we will look at. But we already saw that, for example, the transmucosal fentanyl, which is only approved for like short periods of pain in cancer patients, this increased a lot. So of course the absolute numbers are low, but the relative increase was very, very high. But we don't know yet whether it was in addition to like a basic opioid therapy. And the numbers on the potency were also like that. The more potent, there was an increase in the, only a slight increase, but there was in the potent ones. Yes.
Maybe it would also be of interest to include a measure of patients treated, for example, patients with at least one prescription, or to have a more insights of the
You mean like the prescription prevalence? Or,
patients treated with at least one prescription of opioids?
Yeah, I think we will also do something like this here, but I haven't done so far, yeah.
Thank you.
So our last speaker is Andrew Bashman from Brigham Women's Hospital and Harvard Medical School. He will be presenting tramadol use in the US.
Thanks very much. It's actually Basham, but that's okay.
Sure.
No. Okay. Thanks. I don't know how I'm going to follow all those great presentations, but I'll try. So my name is Andrew Basham. I'm at the Division of Pharmacoepidemiology and Pharmacoeconomics at Brigham and Women's Hospital and Harvard Medical School in Boston, US. And I'm presenting on behalf of a great team of collaborators, particularly my supervisor, Kate Bykoff, and this work wouldn't be possible without them, so thank you all for that. I'll be talking about population-based trends in tramadol utilization in the United States over 2005 to 2021. The funding for this study is provided by AHRQ, and there's some disclosures reported there, and ethics from Brigham and Women's Institutional Review Board are noted on this slide. So this study had 4 aims. So first is analyze trends in tramadol utilization in the United States. Second was to describe the people who are initiating tramadol newly. Third, to quantify the amount of tramadol initiated or initially dispensed. And then to evaluate co-dispensing of potentially harmful CNS agents other than tramadol. So I don't have a lot of methods slides, so I just jump right into the results. But I can describe the data source quickly. So it's Optum Clinformatics data set, which is a nationwide commercial health insurance claims data set. It includes people in our study 18 and up. And at one point, there was a large increase in people 65 and over in the data set due to Medicare Advantage enrollment. So we stratify basically every analysis by age under 65 and 65 plus. And this slide is just sort of to set this, and also Optum is in all the U.S. states, so that's that makes it nationwide, I suppose. So this slide just sets a stage as like the overall use of opioids in the U.S. So oxycodone seen some changes, hydrocodone, Vicodin, a large decrease, tramadol doesn't seem to have changed a lot over the study period, but we'll dive obviously deeper into that. The scheduling status are noted here. So there's an upgrade of hydrocodone to status or Schedule 2 and Schedule 4 for tramadol in 2014. So this is a slide of prevalent use of tramadol. So people with 1 or more prescriptions, these are measured monthly amongst all Optum database eligible members. So these are people who are alive with at least 28 days of health insurance coverage within the month. So they're stratified by age and sex, which was a good point noted previously. And this was also one of the first study to do this, actually, which is somewhat surprising, but there it is. So we can see females 65 and over have the highest prevalence of use, and there's some shifts over time, and we'll talk more about I'll talk more about those in a few minutes. Tramadol initiation, similar pattern, you know, female 65 plus, highest initiation rate. So these are people who did not have any tramadol dispensed within the 6 months prior to a new, what would be considered a new initiation. There's this spike that occurred in 2010, December, which we're not fully clear on its reasoning, but it's there. And if anybody has thoughts, I'd be happy to hear them. So this is looking at state-specific trends in tramadol utilization following the 2014 regulatory change. So here, in this analysis, I used a random effects negative binomial regression model. So this is a way of estimating state-specific trends without over-parameterizing your model by making an interaction between time and every single state. So this method estimates each state as its state's trend as a deviation of the slope from an average slope across states. So what you see here is log difference in the trend compared to that average across state trend. So 0 would be no change no change in the rate of tramadol utilization year to year from 2014 to 2021. So you can see there's a few states here, South Dakota, Arizona, Maine, New Hampshire, and West Virginia, above the 0 line, so positive trend. So those are upward after the Schedule 4 change in regulation status for tramadol. All the rest are downward, or some are near 0 change, so that's something also might be worth looking into further. This is the same thing, but with initiation, so the new initiation with 6-month washout. And the reason they're organized by region, just if anybody's wondering, is just to show that their regions are heterogeneous as well. So often in studies you'll see regional trends, but the state-specific trends are important to note as well, and that's also where policies often are made that can affect utilization. This is a look at painful conditions that are diagnosed in the 6 months before and up to the date of initiation of tramadol. So this is for ages 18 to 64, and it's stratified by 3 time periods, so 2005, 10, 11 to 2015, and 2016 to 2021, just to see if there's changes in the use of tramadol or the reasons it was initiated potentially. So I've circled a few conditions that there was larger increases. I missed other unspecified pain, sorry for that. But you can see that diabetic neuropathy and stage 3 to 4 CKD, chronic kidney disease, there's reasonably substantial increases there. Abdominal pain, osteoarthritis, bone fracture, cancer as well. And then when we look at 65 and over group, you can see similar trends there in those conditions. Back and neck pain also was, it grew substantially. RA and other arthropathies, that's the largest diagnosis group within each of these populations. As you can see, over 40, almost 50% in 18 to 64 and 60% in 65 plus. Dental pain was a kind of an interesting one. I'll mention why in a minute. This slide shows the proportion of initiations that were dispensed by provider category. So the people who are prescribing tramadol, it's changed from sort of primary care, going from 45%. So first of all, on the left side, there's ages 18 to 64, and then you have 3 columns for the year blocks I've used. And then on the right side, there's ages 65 plus with the same year column. So that's how the trends are kind of presented here. So in 1864, it went down from 45% to 31% being prescribed by primary care. And these are categories provided by Optum, so we didn't independently verify that these are indeed their providers, but I'm reasonably confident enough to present them at least. In 65 plus, again, we also see this decline in the primary care group. And some selected specialist groups where we saw an increase, orthopedics, more so in the ages 65 plus group, emergency medicine, and that's consistent with other published research. Saw a large increase, particularly in 65 plus. Well, I guess in both groups actually. Obstetricians, gynecologists, another increase. Oddly, a bit more odd in the 65 plus group that you're seeing an increase there, but a quite small proportion anyways. And then dental providers, large increases percentage-wise, but again, reasonably small, although coming up to 4% in the 18 to 64-year-old group. And this is a group we know doesn't always prescribe in the most appropriate manner, but so that's something. And effectiveness data is a little, is inconclusive in that space as well. So in terms of, how am I doing on time? Okay, great. So the amount of tramadol initiated, so this is measured in morphine milligram equivalents, and this is looking at the year of initiation is on the bottom. Sorry for the month, that just 01 is in January. So we can see this sort of spike in 2010 that was appearing in the incidence or the initiation figure is here as well. Then following the regulation, you can see a decline in the median, and the interquartile range is what the error bars are in this graph. Yeah. Oh. So in terms of days supplied, similar trend. This is the days supplied at the initial dispensing, and it's summing across all potential prescriptions dispensed on the day of initiation. So if they had two different types of tramadol, we captured both. And the y-axes should line up, so these can be compared directly. This is daily MME, so this is like sort of the treatment intensity, or like, and this is a good thing not to see any change in, you know, because we wouldn't want to see a massive change in the way it's being used for people individually. So the prescriptions became smaller, shorter, but the actual dose people are taking daily is reasonably the same, although there is a drop-off, particularly in the 65 plus group, and I'm sorry I keep doing that. Yeah, okay. Last, the CNS agents that are co-dispensed, this is over 30 or under 30 days of the initiation date of tramadol, sort of a mixed bag. We have 3 increasing groups here and 4 decreasing. So gabapentinoids, which we heard about before, is one that has increased substantially, and that's kind of maybe a secular trend rather than a co-dispensing trend, but should be something to keep an eye on. Decreases in other groups is promising. The benzodiazepine increase in the 65 plus also would warrant some more focused investigation, I think. So just some final, just to wrap up discussion points. Tramadol use remains high, even though there's been some decline post-2014 regulation change, and particularly in females aged 65 and over. Downward utilization trends in most states, although upward in a few with no change in others. Declining amounts initiated were observed. We see some shifts in baseline pain conditions and providers. Co-dispensing of gabapentinoids is rare, but it did increase over time. And I think there's a need for some updated effectiveness studies, so RCTs, in terms of some of this newer, or some of the changing spaces are being used in, and evidence is a bit older now. And then ongoing safety research are also needed. Thank you very much.
Thank you, Andrew. And That spike that you saw in 2010, were those crude or adjusted? I'm wondering if there was a data ingestion by Optum at that time.
They're stratified by age and sex, so while not adjusted, you know, you can see that it was across groups.
Do you know the total sample size? Did it increase substantially
Total
that
sample
time?
size, no, it didn't. Well, it was increasing in 65 plus due to the Medicare Advantage group, but again, it's stratified by that, so that shouldn't have any effect anymore. But yeah, I mean, the sample size is like 5.7 million initiations over this whole study period. So this is a large sample. It wouldn't be a small, I don't think, blip like that.
I mean, Optum has continued to ingest data from new sites, new plans, or over time, right? And so I'm wondering if there was some artifact.
Yeah, that's a really good question. No, that is a good point. There is some changes, but the denominator, like, is a proportion, so it shouldn't really affect it in this such a severe way. But yeah, we're still interrogating it. So, but we'll look at that closer. Thank you.
Andrew, thanks very much for your presentation. I'm a bit biased and interested in antidepressant medicines. I'm just wondering, in your final slides, you looked at other CNS medicines. I was just wondering if you'd explored the antidepressants and particularly if you saw any concomitant use, because we know tramadol interacts with some of our serotonergic agents.
We hadn't. That's something we might look at in the future, but no, unfortunately, we hadn't yet. So.
Thank you for your presentation. I just had a thought about the blip.
Oh, yeah.
Propoxyphene or Darvon was removed from the market in 2010. And those managed by that drug probably were moved on to those other opioids.
Propoxyphene and...
Darvon, I think?
That's the branded name.
Branded name.
Oh, okay. Thank you. Yeah, no, that's great.
Thank you.
All right, thanks.
Thanks, everyone, for attending today.